Congratulations! You have come to the last lesson of this video series on the Introduction to Evidence-Based Mental Health. In this last segment of this series, we have been learning critical appraisal of an article on treatment. We have learned how to appraise the article's internal validity and also how to quantify the results. In this lesson, we will learn how to assess the study's external validity. External validity examines if the study results are applicable to the subjects outside that particular study. In Lesson 9, we have seen that an internally valid study would have a design like this. If the study has minimal susceptibility, performance, transfer, and detection biases, then it is likely to be internally valid. Now, we want to know if this study's results apply to other patients with common colds. Random allocation was vital to ensuring internal validity. To ensure external validity, the ideal is random sampling. In other words, we need God's two hands to have maximal internal and external validity. However, there is no way we can randomly select patients from among all the current patients in the world or from all the potential future patients into our study. So we need checkpoints to see if reasonable external validity or generalizability can be expected. First, you must ask, are the study patients so different from your patient that the study results would not apply? Of course, if your patient satisfies all the eligibility criteria of the study, then there is little doubt that the study results would apply. However, for example, if the inclusion criteria for the study was age 18 to 65 and your patient was 67, would you think that the study results would not apply to your patient? Based on all your biopsychosocial understanding of the disease and the patient, you must ask yourself, are the study patients so different from your patient that the study results would not apply? Let's look at our clinical scenario again. Your patient is a 23-year-old male university student. He had his first major depressive episode in his first year in college. He was euthymic for a few years, but he developed his first manic episode in his fourth year in college. The episode subsided after a month's hospitalization. He is in his normal mood state again. Now, let's examine the patient's characteristics in the balance study. Your patient is Japanese and is 23 years old, whereas the study patients are mostly Caucasians with the average age of 43. Your patient's most recent episode was a manic one, and he has been hospitalized once. The global assessment of functioning also appears comparable at baseline. One big difference is that your patient had been stabilized on valproate alone, whereas the study patients had been stabilized on the combination therapy. You may conclude that there is no compelling reason to think the study results would not apply to your patient. Second, We have to guess how large the treatment benefit would be when we apply the results to the patient. The study patients appear to represent a very vulnerable population, requiring a new intervention for an emerging mood episode in 70% and a hospital admission in 20% within 2 years. Your patient may or may not be a little bit less vulnerable, but you decide you can expect a treatment benefit of a comparable size. Third, you would like to examine all potential benefits, harms, and costs when you and your patient make up your minds. Medication change itself can be said to be a surrogate outcome. However, a similar trend in favor of the combination therapy is observed for hospital admissions, while there appear to be no difference in rates of serious adverse events. The costs will not be a major issue as generic drugs are available for both. Having gone through all these steps, you now come to step 4 in the application of evidence-based mental health. What would you do with your patient? We have now come to the end of this video lecture series on the introduction to evidence-based mental health. My heartfelt thanks to every one of you who is listening to me right now for following me through. I hope you enjoyed the series and they will contribute to your practices in the coming days. To recapitulate, in the first section, we have shown you what evidence is and how important it is. In the second section, we followed 4 steps of EBM to solve a hypothetical clinical scenario. As you have by now realized, there are more areas to EBM, such as diagnosis, prognosis, or side effects. We have also seen that we need a systematic overview of the totality of evidence in order to reliably arrive at the underlying truth. In this introductory series, I have not dealt with this. Also, on our way to credible evidence, we need be aware of many pitfalls, most notably among them subgroup analysis, sponsorship bias, publication bias, and so on, that constitute various threats to internal and external validity of the evidence. With your help and support, I hope I will be able to prepare additional video lectures to deal with these problems in the near future. Till then, sayonara, and I wish you all the best with your practices of evidence-based approach to your patients.